Okay, so welcome to the NorCal EMS Run Review for May 27th. It's not May 27th.
No, May 17th.
Oops. It's the 17th. I don't know the difference between my ones and twos yet. I hope to do that by next meeting. So, upon arrival, case 1, 29-year-old chief complaint of code blue hanging, April 27th.
How can the patient have a chief complaint if they're...
I didn't write the PCR.
Okay.
However, I was there. This case, I was there. This was a case down in Merced that I was on the supervisor vehicle who managed to scare the living snot out of me driving code 3. Normally when I do ride along, I'm usually in the back of the bus, looking backwards. I was up front. Yeah, I'm not so sure I want to do that anymore. This was really very sad because when we got staged and when we pulled up, the guy's wife and their 2 young kids were outside the house. So I would assume that his wife found him hanging in the garage. Fire was there and law enforcement was there when we were allowed in. He was found hanging from the inside of his garage by a beam, unresponsive, unknown downtime. The patient initially was asystole with no audible heart tones. He was still warm. There was no lividity. And it was felt that because he was still warm, unknown downtime, the crews wanted to go ahead and try to resuscitate him. So I acted as a fancy EMT. So again, no obvious signs of death. We cut the rope down after law enforcement took their photos, since it technically is a crime scene. Laid him supine down, began to do CPR with a oropharyngeal airway and a BVM. I was the BVMer. We started immediate CPR, airway management. The provider started an IV, first shot really fast, gave epi. After a few rounds of CPR, the patient actually went into VFib. It was shocked at 150 joules. That cured him of being in VFib. He immediately went back into asystole. So continued CPR until the next time we were going to check for ROSC. Shortly after, he had massive amounts of, I would agree with this, the chunky emesis in the airway. Overwhelmed the Yankar. Had to get a washcloth and wipe his face away. It was not the best thing in the world. Got ROSC again a second time. He started slowing down, gave him some atropine while we're preparing to transport because we had gotten ROSC. We put him on a backboard and then we lost pulses again. So we started CPR again. In the back of the ambulance, we had gained ROSC again. Continued to suction, unable to get a manual blood pressure. I was preparing to get an automatic blood pressure. I was preparing to get a manual blood pressure when he rested again, so we didn't get a blood pressure immediately. I started doing CPR in the back of the ambulance. Again, I am impressed that CPR is a young person's sport, where I was sweating. So we actually got ROSC back and transferred him to the nearest ER. Unknown past medical history, allergies, traumatic arrest, cardiac arrest. We did have a brief discussion, and I was somewhat overruled. Initially, they put a C-collar on this patient, and I made the comment that I didn't think it was clinically indicated. But evidently, if they hadn't done that, the ED doc at the base would have chewed them a new one. Having done a hanging study, and you can look that up, you have to have a judicial drop. So you have to drop about equal to your height before you probably get a cervical injury.
I must have read your study because I remember that.
I was way back when I was a medical student.
Oh, well, maybe you just told us about it.
I must have told you about it. So this I have a little issue with, all findings within normal limits, and next time I'm down in Merced, I'll talk to the medic. Yeah, yeah, we'll just leave it at that.
How can his neck be within normal limits if he hung himself?
Exactly. And his tongue was significantly swollen and edematous because of all
I would
the
imagine his pupils were probably had
fixed and dilated.
hemorrhaging going on in there.
He actually had no petechial hemorrhaging. I was amazed, but his pupils were fixed and dilated. So I think he had probably just arrested before we were allowed in, because he was still very warm to the touch. So again, started CPR, manual cervical immobilization, and then we put a C-collar on. He was initially asystole, went into V-fib, couldn't get an initial oximetry, what a surprise. Did 30 to 2, kept suctioning him the whole time. He got epi, and then he got defibrillated. End tidal was good initially, and then we had to change end tidal because it was chunky after that. And so we're not sure what happened to the end tidal. He moved, and again, he lost pulses and gained pulses several times. I was really impressed with the medic who intubated him, which was the VP for operations down in Merced. It was a 2-person intubation. The lead paramedic did it backwards, lifted him up, and then the supervisor slid the tube in. I was doing CPR, they never stopped. And then we did give some more epi after the appropriate time after the CPR had been started. Cords were visualized, they used a bougie, everything was documented well. And then Dr. Javaliki was the receiving doc. So, this is from the narrative. The airway is partially occluded, no spontaneous breath sounds, he was cyanotic. Cap refill really was very, very delayed. Pupils were unresponsive, GCS at 3. So, dispatch at 2:27, we were already cruising around. On scene 4 minutes later, contact within a minute. We were on scene for 34 minutes. I was amazed. I only thought it was about 10 or 15 minutes. It was amazing how long we were actually on scene doing CPR intermittently. As you can see, we were really near the hospital, 2-minute transport. So initially at 22:36, no heart rate, respirations, he was being bagged. Did get a blood pressure at one point of 65/36. End-tidal CO2 was a little low. We slowed up bagging. By 23:02, it had gone up again, so we sped up the bagging a little bit. It made me realize that we really need to institute in NorCal and down there light metronomes, because even though the new Zoll monitors and other monitors have built-in metronomes, nobody ever remembers to put them on. and a 595 or 795 metronome will blink. It's by Lifetimer. It's really very slick.
Gotta have an app for that. Don't they have an app for that, Doc?
Yeah, they do have an app for that. I don't want to take my phone out during a resuscitation. Ooh.
That's what an EMT's phone's for.
Oh. Okay. So here are the times. Good documentation. I did apneic oxygenation, so this person always had a nasal cannula on, even while I was doing BVM. Started an IV, defibbed. Endotracheal tube was placed in the back of a moving ambulance without stopping CPR. So, it was a very educational experience again for me, learning that doing a resuscitation in the field still is incredibly difficult under the best of conditions. There were 3 of us running the code, although fire did help when we were trying to lift him to the power assist gurney. So what do you think of the documentation?
I have personal issues with too much eyes and whatever else that is narrative, but
I don't disagree. I think, having been there, I really can comment on the quality of care. We stopped too much. I did not say a word, but our peri-shock pauses and our rhythm checks were too long. And I had a debriefing with the medic afterward and pointed out my concerns. I think that staying and playing will help, and I think we really need to do some education. Do I think we in NorCal need protocol changes? Yes. I think we don't stop CPR. We don't stop CPR. We don't stop CPR is the take-home message. Anybody else want to have any questions, comments? Since I was there, I can comment on it. Okay. So. What?
what happened to the patient? Did the patient make it or no?
No, they did not.
Okay.
The patient got to the ER. He arrested 2 more times in the ER where they gave him more epi. And I noticed that one of the nurses who was doing CPR was a little over-enthusiastic, because when I counted the rate, it was probably upwards of about 150. And I suggested that they slow up. And the depth was rather deep and vigorous. It was, it impressed me. Again, that's why I wanted the light metronome, so they can know exactly what they're doing. Although I was impressed that this young nurse in the ER could actually do 150 for a prolonged period of time without passing out. Because the short time I did CPR in the garage and then in the back of the ambulance, I was sweating. So I think.
I have a question.
Sure.
Dr. Rudnick. On the intubation, was that in the? You said that was in the ambulance.
Yes, it was.
And one lifted and one placed the tube. Did CPR continue during that?
Yes, it did, because I was doing CPR. I never stopped.
Okay, I want to practice that. Okay.
So the person lifting actually straddled the patient or just leaned over?
The person leaned over. So the supervisor was at the head.
Yeah.
The tongue was so edematous and swollen that you couldn't see. So one medic slipped the laryngoscope in, went from right to left and then up and pulled everything out of the way. Using a bougie, the guy who was quote intubating with the tube found where they needed to go with the bougie, then slid the tube right over the bougie and it went in first shot.
So basically, the laryngoscope was done with a gapping motion instead of the normal.
Correct.
Okay. I just wanted to picture it, and so there it is for the bougie as well.
Yeah. So one person is kind of moving all the swollen tongue and tissues out of the way, and they were on the patient's left, my right, because I was behind them. The guy in the jump seat slid the bougie in, found where he needed to be, because it wasn't the most ideal view, slid the 7.5 tube in. We had good breath sounds, we had good capnography, had great waveform, and then they held it. And I did not stop CPR. I told them I wouldn't stop. They actually didn't even, because I said I'm not stopping, and they didn't even pay attention to me. I was just on the chest doing CPR while they were managing the airway. So it was a 4-person, we had somebody driving. Actually, one of the fire guys drove, and it was a good call. It showed good cooperation between fire, EMS. When I'm in the ER doc looked at me and said, after the guy coded for the second time, what would I do? He said, would you put him on an epi drip? And I said, no. Because you're just going to keep going up and up and up on the epi. I felt terrible because I don't know whether this guy's kids had seen their dad hanging from the roof beam in the garage. I was actually surprised after one epi that he actually went into V-fib. And it was probably because it was pretty new, still a pretty fresh resuscitation. I was down in MSAC last week, and Greg Gilbert, who's the Lemson medical director for San Mateo, was showing experience that they have with the Vivitrac indirect laryngoscopy device. And he showed a couple of codes, and you can see it bouncing. And so they're doing CPR. But having witnessed somebody intubating a patient in the back of an ambulance while CPR is going, it proved to me that you don't have to stop. It can be done, and it should be done, because if you look at the literature, I'm preaching to the choir, but as soon as you stop compressions, if they don't have circulation and ROS, their coronary perfusion pressure goes down to 0 within 2 or 3 seconds. And it'll take upwards of 20, 30 seconds to get CPR to build up the coronary perfusion pressure again. And there was an ICU study done years ago by a guy named Paradis, who showed patients who were in V-fib, if they broke it down, if they had a coronary perfusion pressure between 0 and 15, nobody survived. And what their survival was to get pulse and ROSC. 16 to 25, about 40% got ROSC. And anything above 40, which is coming nearer to physiologic, they got like a 70 to 80% ROSC. Now that doesn't say that these people walked out of the ICU, because in order to be able to measure coronary perfusion pressure and all this other stuff, they're instrumented up to wazoo, and they're really sick. But it just shows that if you don't get oxygen and blood to the heart muscle, game over. So, second case. Dispatched to stage for a male gunshot wound to the abdomen. Responding code 3, arrived at 4 in the morning, Law enforcement cleared the scene, advised to continue, and they did it code 2. They wanted an air ambulance because of the nature of the incident. The first air provider declined. The second one launched. It was delayed due to weather. Then they got canceled by EMS due to, quote, stable vital signs. And that's a key phrase. So, upon arrival, they found the patient lying supine in bed, alert, tracking, law enforcement, and fire. Now, the first thing that I had issue with is they said approximately 1 liter of blood noted throughout residence. How the heck do you know? I have no idea. You know, what's the blood loss? Blood has this thing about how it spreads out. You know, was it a liter? Was it 2 liters? Was it 500? It goes back to what I said at the conference, is you have 2 wounds. You never say one is an entrance and you never say one is an exit. Patient had the most complaints about their index finger and hand, which had been shot, and the pain was 10 out of 10. Patient stated at about 3 o'clock in the morning, an unknown subject entered the residence and fired 1 shot from the handgun, striking the patient in the right hand. Law enforcement noted the bullet path into the opposite wall past the patient, and so there's a hole in the wall. Gets better though. So the patient also relates an abdominal puncture wound, approximately a centimeter in diameter, bleeding control prior to arrival with a pain rated 3 out of 10. I wouldn't have called it a puncture wound. If it's a centimeter in diameter, that's bigger than most knife wounds. I would have said, maybe you shouldn't make the assumption. All I would have said is a wound. Patient denied loss of consciousness, shortness of breath, or dizziness. Pink, cool, and dry. Neck was fine, chest was stable. Lung sounds were good. So the abdominal 1 centimeter puncture wound to the right lower extremity, traveling, and I want to know how they knew it traveled laterally. Who knows? Bleeding controlled again prior to arrival, non-tender palpation, no distension, discoloration, or firmness noted. That's good. That's somebody dropped off. Lower extremity stable without complaint. Upper extremities, right hand, they focus really on this freaking hand. Back was stable, cap refill, all okay. Dress the wound, dress the abdomen. And then code 2 to the trauma center. So what really impressed me is they gave pain meds, started getting nauseated, so they had to get Zofran. No further changes in patient condition during transport, turned over to the doc at the trauma center. Here's the key. The patient's on metoprolol. So that's a beta blocker. That's going to affect things. So when you look at the vital signs, the pulse rate is always from about 65 and a high of 78. So their pulse rate's really low due to the metoprolol. I'm interested that this patient was so hypertensive, so I wonder, was this an automated blood pressure or not? The other thing that I did notice is highly unlikely, but I see it all the time, we all do, doing QA, is every respiratory rate was 16. You know, if you're going to dry lab it, or as some people put it, pencil whip it, make up some other numbers. Just humor me so I don't know it. I'm sorry. I retract that last statement. I'm snide. I'm irreverent. actually take a respiratory rate. It might surprise you. But again, all the vital signs are 16. So, I did find out a little bit more about this case. The bullet never entered the peritoneum. It lodged in the subacute tissue. So, it didn't enter the perineum, it was just under the dermis. So maybe you could have seen the bullet and that's why they said lateral. That's something I would have put in my documentation. So what do people think of the care? I think everybody dropped off, Sean, it's just you and I.
I think so.
Oh, I'm here, Doc.
Oh.
Kathy and I are here still.
Okay, so what do you and Kathy think of the care?
Well, I recognize this from QA, so I think it's a Trinity case.
You didn't have to say that, Kathy.
I know.
I think they focused so much on the hand. I would have been a lot more concerned about the belly. And I would have made light, or at least noted that the pulse rate.
Yeah.
Now, in retrospect,
I think canceling the helicopter, again, we don't know. The comment was that the person said the puncture wound went laterally, and again, if it was just in the sub-Q and you could see that, then it would be less of an indication of, oh my God, they got a bleeding belly, which would be surgery issue. So not flying them with a little bit of hypertension, the heart rate's kind of low. Respirations happen to be perfectly in the middle of a normal adult respiration rate, so therefore they must be stable also. It's not a bad thing to possibly drive. I don't know what the time frame was for the delivery.
I don't know. I think they could have done a better job documenting, because once I found out what the case was and the outcome that, yeah, the hand had to go to surgery, but the bullet was able to be removed because it didn't penetrate the peritoneum, I would have made note that you could see something in the sub-Q, because that would have said, oh. But the documentation on the belly wound, in my opinion, I think the care was good. I don't necessarily disagree now in the retrospective scope, which is always 20/20, that this patient could have gone by ground, but they really focused in on the hand, at least the way I read the chart. So, there you have it. I only have 2 cases this month. So any questions? Huh?
Those were good.
What's for lunch? And are you delivering it?
Well, if you had been here, it would have been Dill's Deli as usual. But no, I am not delivering out to Weaverville. Thank you very much.
You go to Modoc and you go down to Merced, but you won't come to Weaverville.
Hey, let me know the next time you do a 24 shift. I might go out, now that I have my EMS malpractice, and hang out with you and really just bug the snot out of you, Mr. Lane.
You got a 72-hour coming up next week, Sunday, Monday, Tuesday.
Yeah, no. I might do a 12, but I'm not going to do a 72. Just saying. Well, thank you, Kathy and Dan, for staying on, and whoever else was in TV land who may have been there for a while. Hopefully we'll have some good stuff for you to review next month.
When Bill gets, is he going to send out CE thingies?
Yes. So, I have to, let me write that down.
I need all my run audits to keep up with NorCal's policies, so.
Well, good. I'm glad you're keeping up with NorCal's policies. So, CEs for run review. Okay. If there's nothing else, I'm going to say thank you. Say thank you to Mr.
Congratulations, Sean.
Thanks, Dan.
Thank you.
All I can tell you is, having worked with Doc, it's going to always be interesting.
Yes.
I'm not sure how to take that, Mr. Lane. I will take it as a compliment.
Good.
Just
That makes you happy.
whatever makes me happy. Thank you very much. Thank you, Dan. Thank you, Kathy. Have a good one.
Hey, this is Patty. Could you send me a CE also, please?
Patty,
Schultz, SCHULZ.
I will work on that. I have you down as attending, Patty.
Okay, thank you.
You're welcome. Have a good one.
Bye. You too. Bye.